Hi everyone, I'm Alina Isaac, and here we are at the cycle 1 of Advanced Learning module of ID Forum. And we are so happy to see this enthusiasm and excitement of all our viewers right from the beginning of this advanced series. Today, we are honored to have with us Dr. Mohammed Niaz, consultant infectious disease, KIMS Health, Trivandrum. He is an infectious disease physician scientist with expertise in general ID, HIV, musculoskeletal, and transplant related infection. He completed his DM from AIMS, Delhi, and he has already co authored over 60 peer reviewed publications. He has also served as an assistant editor of International Journal of Infectious Diseases. Being recognized as an emerging leader by ISID, he is also currently leading all the AI driven healthcare initiative at Skims Health. Along his clinical practice, he is actively involved in infection control, adult vaccination, and clinical research. And he's a regular speaker at various national and international conferences. And today, Dr. Niaz will be speaking on nosocomial pneumonia. I warmly welcome him to take us through today's session. Dr. Niaz, over to you.
Thank you, Arena. So thank you for inviting me for taking this session. So nosocomial pneumonia is a very important topic. One, this is something that we'll see quite often, and this is a condition that is associated with a quite high morbidity as well as mortality for the patient. And from the Indian scenario, very, very difficult condition to treat. The most drug-resistant organisms that you come across your clinical practice will appear in front of you in this particular clinical syndrome that is nosocomial pneumonia. It's quite hard to treat. The carbapenem resistance is so rampant in nosocomial pneumonia that you will have to really struggle to find a real good regimen that can actually treat these patients. So I'll come with the few definitions. So nosocomial pneumonia comprises of basically hospital acquired pneumonia. So the basically hospital acquired pneumonia is almost the same as nosocomial pneumonia. So these are two synonyms or similar terms and can be defined as a pneumonia that occurs 48 hours or more after the admission to the hospital. And should not be incubating at the time of admission. So 48 hours after admission and should not be incubating at the time of admission. HAP or hospital acquired pneumonia or nosocomial pneumonia is broadly divided into two. One is ventilator associated pneumonia and the second is non-ventilator hospital acquired pneumonia or non-VAP HAP. So these are the broad categorization that we have. As the name suggests, ventilator-associated pneumonia is the type of HAP. So it's a subset of HAP that develops in intubated patients on mechanical ventilation for more than 48 hours. So they should be on ventilator for 48 hours or more. Okay. And then they develop a pneumonia. It's called a ventilator-associated pneumonia. Now, VAP also includes HAP that occurs within 48 hours of extubation. So somebody who has been intubated, you extubate them. So tomorrow they develop a pneumonia, it's also VAP. Okay. So until 48 hours after extubation is also VAP. And non-ventilator associated HAP. Okay, that is NV HAP. That develops in hospitalized patients. It occurs 48 hours after admission, but these patients are not on mechanical ventilation. Okay, so they have developed a pneumonia in the hospital 48 hours after admission, but they are not on mechanical ventilation. That is non-ventilator associated HAP or NV HAP. We used to have a term which was called as healthcare associated pneumonia. So these or HCAP was a pneumonia that occurred in healthcare settings. Like the patient had a recent admission in a nursing home or a hemodialysis center, or the patient had a recent hospitalization. Now, this was a term that was used previously to uh, make people aware that these kind of patients may have an increased risk of drug-resistant organisms. But what it has led into an increased use of antibiotics, okay, high-end antibiotics and overuse of antibiotics. That was what was found for this particular definition. When this particular definition was used, they found there was an increase in the inappropriate antibiotic use, and therefore they have retired this term, they no longer use it. So we now have community-acquired pneumonia and hospital-acquired pneumonia. In the hospital-acquired pneumonia, it can be a VAP or a non-ventilator HAP or NVHAP. These are like a broad classification of this clinical syndrome of hospital-acquired pneumonia or nosocomial pneumonia. Now, why do people develop HAP? Now, ventilator, patients are on ventilator. There are a lot of things that can predispose or increase the risk for somebody to develop infection of the pulmonary parenchyma, which is ventilator-associated pneumonia. So these patients will be on sedation or paralysis medication, okay? And as a result, they don't have the natural mechanisms or the natural protective mechanisms like the cough and the other reflexes by which they can clear the airway, and they are at risk. Positive pressure ventilation by itself can also increase the risk of ventilator associated pneumonia. Now, the endotracheal tube is something that we consider as a protective mechanism by which you prevent macro aspiration. But we should all remember that at the same time, there can be micro aspiration that can occur even if the endotracheal tube is in place. Okay, so it acts something like a direct communication from the environment to the lungs, and bacteria can colonize and form biofilms in the endotracheal tube and around it. Okay, and there is the endotracheal cuff. There is a cuff and with folds along the surface. Okay, and whenever the cuff pressure is reduced, the bacteria can again intrude into the pulmonary parenchyma. In the parenchyma, what happens is that if you see on the left hand side, it's a normal lung. In the right hand side, you can see what happens when the bacteria reaches there. When the bacteria reaches there, as in any other clinical syndromes in infectious diseases, it elicits an immune response. There is chemotaxis of the neutrophils. There are other cells of the immune system. They will generate a lot of cytokines, and there is a kind of inflammation that is happening there. Now, the invading microorganisms with the inflammatory process that is initiated by the body's own immune system is what finally leads to the condition of hospital-acquired pneumonia, specifically in this case, ventilator-associated pneumonia. So this is how ventilator-associated pneumonia occurs. So these are the three, but like how do you exactly suspect when a patient who is admitted in your hospital on ventilator, when do you see, I mean, when do you say that this particular patient is having a ventilator-associated pneumonia? So like the first thing that you look always is X-ray usually, or a CT scan if it's like required. Basically, you start with this, that is, you have the presence of a new or progressive radiographic infiltrate. Okay, this should be there with other signs of infection, which can be fever, which can be purulent respiratory secretions. Some patients can have leukocytosis or leukopenia, and you have worsening oxygenation. Okay, that is increase in the O2 requirement, that is the FiO2 or the PEEP requirement. Okay, so that is the pressure required to maintain oxygenation. So this is when you suspect. When you have an infiltrates in the chest X-ray, it can be due to multiple conditions, especially in a patient in ICU, it can be due to fluid overload, ARDS, and other conditions. But when you have other signs of infections associated with it, such as fever, purulent respiratory secretions, leukocytosis or leukopenia, worsening oxygenations, and like with increased oxygen requirement or the PEEP that is required to maintain oxygenation, that is when you suspect ventilator associated pneumonia. Clinically, you diagnose ventilator associated pneumonia. Now, now that is diagnosed, you know that all of these clinical symptoms are caused by microorganisms, and you need to find out exactly what is the organisms that actually causing ventilator-associated pneumonia. And for VAP, like there has been a controversy whether you require invasive sampling or a non-invasive sampling. A non-invasive sampling refers to your endotracheal aspirate, which is quite easy to get. Okay, you can aspirate from the endotracheal tube and send it for culture. Now, the invasive sample requires an invasive procedure like a bronchoscopy, okay, or a mini valve. Okay, that's some kind of a blind valve that you do. So a bronchoscopy or a blind valve or something called as a protected specimen brush or the PSB. So these are the methods by which you get a specimen for microbiological investigation in a patient with suspected ventilator-associated pneumonia. So if you look at endotracheal aspirate, this is what is called as the non-invasive sampling. Does not require a bronchoscopy here. So it's a non-invasive sampling. So if you have a non-invasive sampling, you need a higher bacterial load. And to call it as a positive culture, so you need to have a culture equal to or more than 10 raised to 6. Okay, so that is when an endotracheal tube culture is said to be positive. Or like this invasive sampling, which you directly take from the lung, a lower threshold of bacterial colony count is sufficient. For example, if it's a BAL or a mini BAL, you may consider it as positive if you have a colony count of 10 raised to 4. A protected specimen brush, you will take it as 10 raised to 3. Okay, so these are the techniques by which you obtain samples. What does the guideline say? Which technique to use? So the IDSA guideline says that non-invasive sampling is enough with semi-quantitative colony count estimation is enough for the diagnosis of the microbiological investigation. The European guidelines, on the other hand, currently prefers invasive sampling because these samples are associated with less risk of contamination. The problem with ET aspiration, whenever a patient is intubated for a long, any culture like that you take from an ET like an endotracheal tube after a long ventilation is going to give you a positive report, and you cannot treat these patients with just because of that. So endotracheal, a non-invasive sampling at that aspect is a inferior kind of sampling, whereas invasive sample that you get from a deep inside the lung, that is by doing a BAL, mini BAL or a PSB, has a better chance of being a real infection. Okay, even in that case, there can be problems, but better than a blind endotracheal tube aspiration. So there are other methods also, like molecular methods that you would have come across, like panels which can identify bacteria. So one of the commonly used panel that is used for the diagnosis of pneumonia as such is the pneumonia plus panel by, it's called as a film array pneumonia plus panels, and by the BioFire film array pneumonia plus panel. BioFire film array pneumonia plus panel. So this is something that is used in our hospital as well. If you could look at that, it detects various bacteria. Okay, so the bacteria includes the gram negatives, including the common causes of ventilator-associated pneumonia, like the Acinetobacter. Okay, you have the Klebsiella pneumonia. Okay, and Pseudomonas aeruginosa, Staphylococcus aureus, etc. So these bacteria are there, and it also gives you a relative number of its genome copies by one number called as a bin number. Now, you should not confuse the bin number with the CFU per ml number. These are two different numbers. The bin number only gives you a relative number, okay, of the genome of a particular bacteria. If you look at that here, you can see the bin number of Klebsiella pneumoniae is like around 10 raised to 7, whereas for Haemophilus influenza is 10 raised to 4, only means that relative to the Haemophilus influenza, the genome of the Klebsiella pneumoniae is quite high, and for that reason, this may be the actual organism causing the pulmonary infection. And this again is not very like what foolproof or anything like that. Just because it's a PCR, don't jump into conclusion just based upon this particular test. Very likely that many of the times, if it is not done in a patient in whom this test is indicated, it will actually lead to increase in the antibiotic consumption. We have proved this in our own study, like where we looked at what happens in antibiotic use after the film array pneumonia plus panel. It increases the antibiotic use of the use of the reserve antibiotics actually goes up after the film array reports actually. So if you have a definite diagnosis of a ventilator associated pneumonia clinically, then only you should be doing this kind of test. Now, if you are having a pulmonary, like a patient with pulmonary edema, and you sample, still you get some organism because the PCR is a very sensitive test. Many of these organisms may be colonizers. They are not actually causing the infection, and you're just harming the patient by causing initiation of high-end antibiotics. You should not do that. So what is the indication for doing this test? Is you have a high strong clinical condition. There is a high pretest probability that it is a pulmonary infection. Then only and then only you should be sending a pulmonary BioFire pneumonia plus panel. The panel also will tell you the resistance genes, including the ESBL genes, the carbapenemase genes, and the methicillin resistance in staphylococci. you have the atypical bacteria like chlamydia, Legionella pneumonia, and Mycoplasma pneumonia as well. Then you have the respiratory viruses, which can also cause various pneumonias. So this is the pulmonary pneumonia plus panel. Okay. Now, this is something that I've been already telling you, ET culture or an ET pneumonia plus panel positivity, it does not mean that. Okay. Just because an organism is isolated or just because an organism is detected in the pneumonia plus panel, that doesn't mean ventilator-associated pneumonia. That doesn't mean this is the organism that is causing the pulmonary infiltrate. The clinical diagnosis is very, very, very important. The patient should have pulmonary infiltrate, then they should have features suggestive of infection, which can be in the form of fever, increase in purulence of secretions, or they can have a worsening of oxygenation, or they have leukocytosis or leukopenia. Some of these criteria, at least two actually, should actually fulfill to actually suspect VAP. And in that situation, when you have a very high colony count of an organism, you may consider it as the possible etiological organisms. Acinetobacter, etc., for example, often colonize the endotracheal tube, and whenever you actually do a culture, actually it will be I will be surprised if it is not growing. ET culture always will grow something. Okay, so you send it not for every fever. You don't send for any, like you have a fever and you don't know the source. So let us say, like, let us take some the pan cultures, the blood culture, the ET culture, the urine culture. You don't do it like that. Only if you have a definite evidence of a pulmonary infection as the conditions which I already mentioned, you will be sending ET culture or a ET pneumonia plus panel. Okay. Now, yeah. You should also like we have been talking when you should suspect, I mean, ventilator-associated pneumonia by a clinical definition, which is pulmonary infiltrates, along with increase in purulent secretion, fever, or you have leukocytosis, leukopenia, or increase in ventilator requirements. Now, there is also another definition, which is the CDC NHSN surveillance definition, which is used for the diagnosis of VAP. This is a different, entirely different definition. This is not something that we use for clinical. This is for surveillance used by infection control people. Okay, this is not something that we use for clinical diagnosis. You don't wait for all these criteria to fulfill to diagnose somebody as VAP. Now, ventilator, like when this particular definition by CDC defines ventilator-associated condition first. This is like if patient has been intubated, the patient has a 2-day history of stability, that they have been stable for 2 days, nothing much has happened for at least for 2 days. Then when their PEEP increases by more than 3, equal to or more than 3 centimeters of water, or it's their FiO2 increase by like 2, that is 0.20, that is 20%, and that increase is sustained for at least 2 days, you call it as the ventilator associated condition. Okay, again stressing this is a surveillance definition. So for surveillance definition, you start with what is called as a ventilator associated condition. Somebody on ventilator stable for 2 days, their PEEP increases or their FiO2 increases, and the increase is sustained for more than or equal to 2 days. That is a ventilator associated condition. And then when a patient with VAC, okay, also has, okay, either a fever more than 38 degrees Celsius or hypothermia, or they have a WBC count more than 12,000 or less than 4,000, or a new antibiotic has been started and continued for at least 4 days. That you call as an infection-related VAC or IVAC. Okay. Now, IVAC patients, okay, these patients, okay, when they have purulent secretions, okay, and in the secretions they do a gram stain, it shows more than 25 neutrophils and less than 10 epithelial cell per low power field, or they have a positive respiratory culture. Okay, so they satisfy the criteria for IVAC. Second, they have either purulent secretions as documented by a high neutrophil count more than 25 or less than 10 epithelial cells per low power field, or a positive respiratory culture, okay, taken by sputum, ET aspirate, bag, lung tissue, or protection specimen brush. You call it as a possible ventilator associated pneumonia, PVAP. Now, again, stressing, why are we using this? This is used whether the VAP in a particular hospital is going up. Okay, this is not for patient management, it's surveillance. The rates are increasing, you use a very strict and stringent definition. And if you wait for every patient to satisfy all the condition to diagnose clinical VAP in a patient. Okay, so you are going to lose most of your patients. Okay, because that is not what happened clinically. Clinical definition is something that I've already mentioned. This is entirely a surveillance definition that is used for infection control practices. Now, again, your antibiotic of choice will depend upon what are the organisms that cause VAP in your hospital. You cannot rely on international guidelines. You cannot rely on guidelines from the international, like the IDSA or the ESCMID to decide what is the empirical treatment of ventilator-associated pneumonia in your hospital. So in your hospital, you should have your own antibiogram, which will actually tell you what is the actual cause of VAP, which is in your hospital, in your epidemiological setting. So for example, for us, we have the antimicrobial guide therapy, which gives us the organisms which were responsible for VAP. It's actually ET culture that has been obtained after 48 hours. Some of them may be colonized, but it gives you an idea what are the organisms which are usually implicated in VAP. For us, in the last year, it was Klebsiella pneumonia, Pseudomonas aeruginosa, Acinetobacter, followed by E. coli. If you look at Klebsiella pneumonia, if you can look at for meropenem, for example, here, the meropenem susceptibility is around 50%. That is a 50% Klebsiella carbapenem resistant. Okay, that is CRE, that is Klebsiella pneumonia. If you look at Pseudomonas, the susceptibility is slightly better. Around 80% is susceptible to ceftazidime, sulfoperazone, sulbactam, piptas, etc. So that's fine. But then comes the major, like again, another villain, that is Acinetobacter baumannii. If you look at the susceptibility of meropenem, it's only 26.80%. Three-fourths of Acinetobacter, okay, three-fourths of your Acinetobacter that is obtained in patients with suspected VAP, that is ET cultures, are actually resistant to meropenem. So these carbapenems, which are like recommended as first choice, or Paracetamol tazobactam, which is recommended as like first choice in VAP in the Western countries, these guidelines are not going to be applicable in India. If you start such antibiotic, patients are not going to improve, and in fact, they can deteriorate. That is something that we have to remember. Now, antibiotic stewardship is not just about cutting down antibiotic. It's about optimizing antibiotic. So in patients with ventilator-associated pneumonia in the Indian setting, I believe this is the situation in majority of the Indian hospitals as of now. So stewardship is not just cutting down antibiotic, it's using the right antibiotic, the optimal antibiotic. And in VAP patient, it's not a carbapenem, it's something more than that, has to be used based upon your epidemiology. Now, again, this is something, just a graphical representation. I've already mentioned for meropenem, for Klebsiella pneumonia, the susceptibility was 50%, whereas for Pseudomonas, quite well, more than like 70% susceptibility for the commonly used antibiotics compared to the others. And for Acinetobacter, very poor susceptibility, especially for even for meropenem, like the susceptibility is somewhere around 26%. Okay, and susceptible agent, if you look at even digicycline, not very good, like around 58 to 60% for minocycline as well as digicycline. So these are really tough conditions to treat actually. That is why, like I told in the first, it's like ventilator-associated pneumonia is one of the most difficult condition or like clinical symptoms to treat in our setting. So accordingly, what is the antibiotics of choice that you consider in our hospital antibiogram? So for us, as you were told, like the major organisms for Klebsiella pneumonia, Acinetobacter baumannii, and Pseudomonas aeruginosa. Some of you will be really shocked to see that this regimen that you recommend. That is, if you have a real ventilator-associated pneumonia, our drug of choice, the first line regimen that we suggest is polymyxin B plus high dose tigecycline or minocycline. Now, obviously, these are last agents. These may not be good agents compared to the beta lactams. That's all true. But let us also understand that the other agents are not going to work. Carbapenems are not going to work. The beta lactamase inhibitors are not going to work. We are in a situation, these are the few drugs that can only be trusted as a first line therapy for ventilator syndrome pneumonia. The outcomes actually may be not very good. We are waiting for newer antibiotic. But that is the situation of antimicrobial resistance in ventilator associated pneumonia. So polymyxin B as of now remains highly susceptible to both Klebsiella pneumonia, Acinetobacter, and even Pseudomonas aeruginosa remains at least in vitro susceptibility is quite good. We all know that These are the agents which are associated with high clinical failures in many studies, but we don't have options at this particular point of time. Second agent that we use is tigecycline. Tigecycline is against effective against carbapenem-resistant Klebsiella pneumonia as well as Acinetobacter. Acinetobacter again not very good. That is why we use it in combination. So this is the regimen of that we use as empirically. Now, whenever you use an antibiotic for a clinical condition, be it PVAP, HAP, or any other condition, there are few clinical there are few criteria that you actually look at. So one includes the likely pathogens and the resistance risk. We have already described the common organisms in Indian ICUs are Klebsiella pneumonia, Acinetobacter, and Pseudomonas. For us, usually it is Klebsiella and Acinetobacter. This year, somehow we got a bit more number of Pseudomonas. Patient-specific factors, their risk factors, their clinical comorbidities, whether patient is immunosuppressed or not, those things are very important. Patient's renal status is important. Patient's hepatic status is important. Patient's weight is important. Whether the patient is on CRRT, patient is ECMO, these are all very, very important. Patient-specific factors that you should look at. PK, PD is very important. How do you optimally dose these antibiotics? Whether a prolonged infusion is required if it's a beta lactam sensitive agent, that is one thing. Second is what is the concentration of the drug in the epithelial lining of the lung. Okay, that is the ELF. Okay, epithelial lining fluid. What is the concentration of the drug ELF? Whether it has a good penetration to the ELF of the lung. That is another question. Safety profile and drug interactions. We say that you use polymyxin B, but you know the polymyxin is associated with nephrotoxicity. Many other drugs that we use are like associated with other side effects, like all these newer like high-end antibiotics have their own side effects. Whether you're using the drug, whether the benefit of the using the drug actually justifies the risk that is associated with this. Stewardship and de-escalation plan should always be in the mind of a clinical pharmacist, especially start a high-end antibiotic. You have a culture which shows that the organism is susceptible, you should de-escalate. And logistics is very important. Some of the antibiotics may not be available in your country. For example, cefiderocol, which is used in other countries, may not be available for you. So all these factors actually decide what is your antibiotic that you're going to use, what dose you're going to give, and how long you're going to give. So all these parameters should be considered by any clinical pharmacist who are going to treat, be involved in the management of ventilator-associated pneumonia. Now, this is an algorithm that we usually follow. So ventilator-associated pneumonia, you start empirical antibiotics. You're already told what is the regimen. Now, if it's a carbapenem-resistant pathogen, it's a CRKP. So you can assess what is the carbapenemase type. Or you can do a ceftazidime-avibactam sensitivity or ceftazidime-avibactam aztreonam synergy. So it's a KPC or OXA48. They usually will be susceptible to ceftazidime-avibactam. So you can treat with ceftazidime-avibactam. If it is the metallo-beta-lactamases, okay, the MBL, the most common metallo-beta-lactamase in India is NDM, okay, or the other enzymes, VIM, IMP. You give ceftazidime-avibactam with aztreonam, okay, ceftazidime-avibactam with aztreonam, right? For carbapenem-resistant Acinetobacter baumannii, Acinetobacter baumannii, the treatment options include polymyxin B, tigecycline, or minocycline, and in some situations we use triple therapy with high-dose sulbactam. Also, we add to the regimen of ventilator-associated pneumonia. So other organisms, maybe carbapenem-resistant other organisms or not carbapenem-resistant organism, the treatment will depend upon the susceptibility and the organisms that is isolated. This is something that we follow. This is no international guideline. This is what is the epidemiology that we face, and I believe that's the epidemiology that most Indian ICUs face, and that is why we follow this particular algorithm. So let us come into detail again with these agents. Though these are kind of always touted as inferior agents, unfortunately these are our only go-to antibiotics in case of carbapenem resistance. So treatment options for Acinetobacter, which is the most difficult bug to treat nowadays, especially in hospital-acquired settings. We have the polymyxins, as I have already told, is one of the drugs that we use. Now, you know that the polymyxins can be divided into colistin, also called as polymyxin E, and polymyxin B. So polymyxins are broadly divided into colistin and polymyxin B. So compared to uh, if you look at these two agents, that is between polymyxin B and colistin, what is the preferred agent that you use in a patient with VAP or other systemic infection? Okay. Now, polymyxin B is administered as its active form itself. Okay. It's administered as its active form. And this active form has a renal clearance, which is not a major method by which it is cleared. And there are other clearances, okay, which is a much more common methods, okay. Non-renal mechanisms of clearance are much more common. That is the reason by which this particular drug, it's not a prodrug, it's administered in its active form, so it can act very immediately. Second, it has less renal clearance, so there is no need for a renal modification of its dose in renal impairment. On the other hand, colistin is administered as its prodrug, okay, that is colistin methane sulfonate or CMS, which has to be converted into its active form, that is colistin. All right, and a good portion of the CMS is actually excreted to the kidneys. Okay, and lesser part of it's actually excreted by other mechanisms. So there is a higher clearance of this particular drug, that is colistin, by renal mechanism. So this drug has to be modified when the patient has a renal impairment. So renal impairment dose modification is required for colistin, not for polymyxin. So if you compare both drugs, polymyxin B, as I've told, is given as the active form. It can act immediately, okay? And as a result of which, more predictable action, more faster action, it's preferred for systemic use. But its renal excretion is low, renal clearance is low, therefore low urinary concentration is not preferred for UTI. What is preferred for UTI is colistin. So UTI, high urinary concentration, colistin is preferred. All other systemic infections, including ventilator-associated pneumonia and hospital-acquired pneumonia, polymyxins are the preferred drug. This is something that we already mentioned. It's given as the active drug form, whereas colistin is a prodrug which has to be converted. Okay, not affected by the renal function, that is polymyxin B. On the other hand, colistin is affected by the renal function, and you have to modify dose accordingly. Because polymyxin B is given as active form, the rapid and predictable onset, whereas for colistin, it's a slower and variable onset of action. Polymyxin B is associated with a lower nephrotoxicity, whereas on the other hand, relatively colistin is a higher nephrotoxicity. So altogether, we prefer polymyxin B, okay, poly B, when you compare it with colistin in ventilator-associated pneumonia and hospital-acquired pneumonia, if you have to use. Obviously, if you have a better option, you can use it, but just mentioning, comparing between the two polymyxins, polymyxin B is better than colistin for systemic infections, including ventilator-associated pneumonia. So whenever you use it, like when for polymyxins, like when you have to, like when you're using polymyxin for enterobacterials or Pseudomonas aeruginosa or Acinetobacter, you have to look at the susceptibility. And it is, whenever you look at a susceptibility report, nowadays they don't mention it as sensitive, okay? If its MIC is less than or equal to 2, it's like reported as intermediate. It's more than or equal to 4, it is resistant. There is no sensitive category. Now, why don't put like sensitive category as per the CLSI? This is because the CLSI considers, because of the high failure rate of this particular drug, they are told that people should not think that this drug will work when you give it as a sensitive. So that is why this criteria is given only as intermediate. Even if the MIC is less than or equal to 2, it will only mention as intermediate. You will never find a report which says that colistin is sensitive. Okay, if it is, the microbiologists are not aware of how it is to be reported. So if you have a colistin susceptibility, you can indirectly infer that polymyxin B also is susceptible. Okay. Right. Now, what are the doses that you have to give? So polymyxin therapy, like somebody have done a therapeutic drug monitoring in carbapenem-resistant organisms, studies from China. And what they found was that, like, if you have a higher dose, okay, the target exposure, the PKPD target exposure and target attainment is better than a lower dose. That is, 150 milligram loading dose followed by 75 milligrams 12th hourly dose. And there was no difference in the 14-day response in this particular study, which looked at polymyxin B at lower dose and higher dose. There was no clinical differences. But long-term survival, there was a difference. Like in the high dose group, there was a better survival. But I don't think that's a very important. If you have a ventilator associated pneumonia, I don't know why they're looking at 180-day mortality. And the AK incident was mild and was comparable between the groups. Now, as of now, what I want to tell is that the high dose is not associated with an increased risk of nephrotoxicity as per the recent evidences. So the current recommended dose is to give it a higher dose of 150 milligram loading dose for 75 milligrams 12th hourly dose. So this in our setting is mentioned as units per kilogram, 25,000 units per kilogram loading, followed by 12,500 units per kilogram IV Q 12th hourly. So this is same as this. So a higher dose of this is actually being practiced. Again, inhalational polymyxins, like something again a very controversial. We all know like polymyxins, like given systemically for many conditions, like including VAP, whether you should be giving inhalational polymyxins. Okay, now there are various schools of thought. Like I mean, evidences actually differs. Actually, nobody exactly know whether this thing actually works. Now there are like has been some recent meta-analysis which has shown that there may be some role for inhaled polymyxins, even though many of the guidelines still do not recommend it. So in patients who are not improving even with the systemic therapy, and it is a carbapenem resistant bug sensitive to polymyxins, you may try inhalational polymyxin at that situation. And this meta-analysis by Zhou et al., which was recently published in Critical Care 2024, where they compared intravenous plus inhalational polymyxins versus intravenous alone. They found that there's been a mortality benefit when you use the intravenous plus inhalational route. Okay, so like meta-analysis keeps on gives us different results every year. Now, as of now, this is the latest one. There is some role again. It's controversial is what I can say at the best. So when you are using, if you are using inhalational polymyxin, polymyxin B actually here is likely to cause airway complications like bronchospasm. Here the colistin, okay, nebulized colistin is the preferred agent. So again, colistin breakdown products also can cause damaged lung tissue, like it can cause damage to the lung tissue and cause bronchospasm. You have to be careful. And this risk is higher if the solution is prepared more than 24 hours before use. You take out colistin and prepare the solution 24 hours before. The risk of bronchospasm is more. So as clinical pharmacists, even if like any time you're using inhalational colistin, it has to be freshly prepared immediately prior to the administration. Okay, should not use previously prepared solutions. Prepare it immediately prior to administration. Nobody knows exactly how much dose has to be given. The typical dose that is given is 2.25 to 4.5 million international unit CMS PD. Okay. Tricycline is the second agent that I was telling as used as like I mean again empirical therapy. Tricycline is controversial. One of the studies where like they have used this particular drug was associated with like a higher mortality, and there was signal that was an increased mortality in that arm. But still, there are situations in which we are forced to use particular medicines in VAP. In VAP, you have to use tigecycline of a higher dose. The normal dose of tigecycline is 100 milligrams TAD followed by 50 milligrams BD. Whereas for tigecycline VAP, the dose will be 200 milligrams TAD followed by 100 milligrams BD. So higher dose of tigecycline in VAP has been associated with low mortality, higher clinical cure, and microbiological eradication, and without an increase in adverse effect. So as a result of which, this is the dose that is usually given for ventilator-associated pneumonia. Another agent which is recommended as the first choice of drug is sulbactam, that is high dose sulbactam. Okay, so we know that sulbactam is available as sulfoperazone sulbactam or ampicillin sulbactam, which is more available in the Western countries. We have both actually. I don't think sulfoperazone sulbactam is an FDA approved drug, which may not be available in the US. So high dose sulbactam has been mentioned, like in the IDSA guideline, as a combination. Okay, you give ampicillin sulbactam in the higher dose so that because they don't have plain sulbactam. India plain sulbactam is also available, so we usually use pure sulbactam alone without the ampicillin component. So sulbactam is a beta lactamase inhibitor, okay? But unlike the other beta lactamase inhibitor, it also has intrinsic activity against Acinetobacter baumannii. Okay, that is something peculiar for sulbactam. Uh, Intrinsic activity against the Acinetobacter baumannii complex. It's particularly on binding to this penicillin binding protein 3 and penicillin binding protein 1A and 1B. Because of this, Acinetobacter can be inhibited to an extent by sulbactam. Okay, now sulbactam, remember that sulbactam can be neutralized by various other enzymes which are present in Acinetobacter. This include OXA23, OXA24, TEM1, ADC30, and Indian setting also there are many of the Acinetobacter which has NDM. So even if Acinetobacter can block PBP3, the bacteria won't allow the Acinetobacter to reach PBP3 sometimes. Even before that, many of the enzymes like OXA23, NDM, etc., can actually uh, cause degradation of cell bacteria. So if the MIC of the, like, how do you find that there is a high degree of resistance? So if the MIC, you have to look at the MIC of ampicillin sulbactam. If the MIC is more than 64, its high dose sulbactam is unlikely to work. And Indian setting, majority of the isolates has a very high MIC. So whether high dose sulbactam actually work in the Indian setting is a questionable thing. If you have a lower MIC, that is 16 or 32, even these are higher actually, but you may consider adding this as a third drug. Okay. So triple therapy sometimes may need to be given in VAP caused by Acinetobacter baumannii. So there is a new drug which is going to come. It's a sulbactam durlobactam, which has been found to be better than colistin for the treatment of Acinetobacter infection in a trial called as the ATTACK trial. So sulbactam durlobactam, you know, sulbactam binds it's a beta lactamase inhibitor that inhibits PBP3, PBP1A, and 1B. Whereas durlobactam is another beta lactamase inhibitor. It's a new generation. It can inhibit oxa carbaphenamase. We told that oxa23 everything like inhibits the sulbactam. So it will protect sulbactam by inhibiting oxa23, oxa24, oxa58, and class A and class C beta lactamases. Unfortunately, it does not have effect on NDM. So whether it will work on Indian isolate is a question. But favorable response has been studied, like seen in Indian isolates as well. Like this study, which in vitro assessed whether sulbactam durlobactam has action against isolates from India. Sulbactam durlobactam, if you see, only 11.5% of the Indian isolates were resistant to sulbactam durlobactam. So we have to see the clinical situation. Like when it comes, actually, it has been approved by the FDA very recently. We hope the drug will be available for us as well. Okay, so let us wait for the drug. Another drug which may have effect on Acinetobacter, which is coming up as an Indian product, that is cefepime zidibactam. So cefepime zidibactam is another molecule that we are eagerly waiting for. It in vitro has good action against Acinetobacter baumannii. The trials are ongoing, so let us wait for the reports. I mean the results, and like let's wait for the drug to be released. So this is like when like basically like when this is an article which is looking at the timeline of various treatment options for Acinetobacter baumannii. Previously, they used to use colistin as a regimen. Colistin plus rifampicin was like in 2013, etc. There was a study with compared colistin versus colistin plus rifampicin, and colistin monotherapy was like equally, in fact, better. So they like when then they used this combination of colistin plus meropenem as one agent versus colistin alone. Adding meropenem actually did not improve anything much to this is all treatment for carbapenem resistant. So then colistin monotherapy was there. Then there was studies in which like when they have looked at a newer molecule which is called as a cefiderocol in a study called as a credible CR. What they found was there was higher mortality in the cefiderocol arm. Though still again in dire situation, you may still have to use cefiderocol, but it's not available in India. You will have to import this particular one. And finally, you have this particular study, which is called as the ATTACK trial, which compared sulbactam durlobactam versus colistin. and was called like Cellbacter Relobacter was found to have a better uh, outcomes in compared with cholesterol. So multiple options for this particular bug means like, I mean, none of them are actually very perfect. Even now, like the mortality in Acinetobacter baumannii WAP actually remains quite high. Okay. Now, we were talking about Acinetobacter baumannii for a long time, but then you have the other end, that is Klebsiella pneumonia, carbapenem resistant, which is the other most common organism. So we have already told, if it's a Klebsiella pneumonia, which is carbapenem resistant, the treatment will depend upon whether it is what is the enzyme. The enzyme is KPC or OXA48. The treatment will be ceftazidime avibactam. Okay, this is the agent, but that is the drug of choice here. And secondly, if you have the metallo-beta-lactamases, the metallo-beta-lactamases includes the NDM, this includes the VIM, it includes the IMP. If these are the organisms, then ceftazidime avibactam alone will not work. You will have add ceftazidime avibactam plus aztreonam. So what is the funda? So aztreonam can inhibit the metallo-beta-lactamase, but aztreonam is not stable against ESBLs, AMCs, and the KPC, etc. So ceftazidime avibactam can inhibit, it can inhibit ESBL genes, enzymes, it can inhibit KPC, OXA48, we already told that, and it can inhibit AMCs as well. So all these are inhibited by ceftazidime avibactam. So this combination can be used for the treatment for our, like me, patients who have NDMVA IM. Why? Because when you have these particular genes, most of the times they have along with that some other genes like ESBL, KPC, etc. So it usually don't occur alone. So you have to inhibit the other resistance mechanisms as well. So as there have been studies in which the efficacy of ceftazidime avibactam has been proved, though ceftazidime avibactam was compared with meropenem in isolate, which was susceptible to both. They were not carbapenem resistant in a trial called as a reproof trial. And ceftazidime avibactam was found to be non-inferior to meropenem. So it has a good action in pneumonia. It has been proved. So it can be used. And when will you use it? When the organism is carbapenem resistant. What kind of organism? Enterobacterial, especially Klebsiella pneumonia, which is a common enterobacterial which causes pneumonia or ventilator-associated pneumonia in our setting. Now, how long will you treat? How long will you treat this patients like ventilator-associated pneumonia? So the guidelines is the IDSA guideline for WAP was in 2017, maybe upgraded very soon. As of now, 7 days of treatment is sufficient. Okay, 7 days of treatment is sufficient for most patients. Now, guidelines say 7 days. Most of the patients, 7 days will be sufficient, but there are maybe a subset of patients you may have, like, but depending upon the clinical situation, you may have to increase the duration of treatment. But for most of the patients, 7 days is enough. Even after the release of the IDSA guidelines in 2017, in 2023, there has been a meta-analysis which compared longer duration versus shorter duration. And what we can find that there is no statistically significant difference in outcomes, that is mortality, in patients who received a 7-day course or more than 7-day course. So the short course was not associated with a higher mortality. So as of now, 7 days is enough. The previous meta-analysis, sometimes it was said that when you use for non-fermenting gram-negative bacilli, which includes Pseudomonas and Acinetobacter, there was an increased risk of recurrence. This particular study found that even in NLFs, that is non-fermenters, Pseudomonas and Acinetobacter, there was no adverse outcomes when you use this 7-day therapy compared to a longer day therapy. So as of now, the standard duration of treatment for ventilator-associated pneumonia is 7 days and not more than that. Okay, so for most of the patients. So this is a nutshell regarding ventilator-associated pneumonia. The treatment, the epidemiology of hospital-acquired pneumonia is almost the same, but just that these patients are not ventilated. But if somebody is acquiring an infection in the hospital and it's a pneumonia, the epidemiology is almost the same, and you treat it exactly as the same as a ventilator-associated pneumonia. So to recapitulate, VAP and HAP are conditions associated with very high mortality and morbidity. In our setting, Acinetobacter baumannii, Klebsiella pneumonia, and Pseudomonas aeruginosa are the most common organisms, and a good percentage of them are carbapenem resistant. When you are deciding an empirical therapy, it should depend upon your hospital epidemiology. Most of the Indian hospitals, the carbapenem resistance are rampant, and agents which are active against carbapenem resistance should be used. And for specific agents, we have mentioned what are the drug regimens that has been used to treat HAP or VAP. Thank you.
So, thank you so much, Dr. Mohammed Niaz, for that wonderful session. It was very comprehensive, insightful. So, I was quite amazed. Actually, I'm not amazed because this is the scenario in my institution as well. To see that high dose tigecycline and poly B is used as an empirical therapy. So, so this is a question that I and my ID physician usually talk about this. We always make anti-diagram, but we hardly take that time and effort for making a syndromic anti-diagram because we always, the data that Nia sir was also showing, like the ET secretion after every 48 hours. So there also we don't have that proper discretion whether the syndrome diagnosed was HAP or VAP. So,
Understood.
and or our clinicians also bounce back to us, your ID pharmacist, why do you ask us to give the high end antibiotics? So I think you will also ask the same.
Yes, yes. No, no, like, I mean, as you said, like, it's a misconception that we are people just cutting down antibiotics. We are people who are optimizing antibiotics.
Yes.
So whenever it is need to be escalated, it needs to be escalated. So you're right that many of these ET secretions will actually be colonizers sometimes. But our experience is that even in clinical lab, this is the same situation. Like when these are like when the representative of the clinical situation, and I believe it's the same. Even the institution where I've worked previously, it was even worse. So that unfortunately situation, we have a long way to go in terms of antibiotic public stewardship. But until that, you can't wait and for that to improve to treat your patients. The
Yeah.
treatment, like the patient in front of you, is the most important, and that patient has to receive the optimal antibiotic.
Yes, exactly, sir. And also, as you also said, that tigecycline use is controversial, yeah, because FDA label also says tigecycline is not approved for use in vapor HAP and also in diabetic food infections. But still, we
Yes.
don't have a choice, so we go for it.
Definitely, yes. These are all like when we are in a situation we don't have options. That is the only
Yeah,
reason. Like it's
exactly.
not that we are very happy using them. So we are waiting for better antibiotics. As I told us, we are like we have to see if sulbactam, durlobactam works in Indian situation. In vitro data says that it may be an option. Second
Yeah.
is ifipane zedibactam. That is one drug which can change scenario. That's what I believe. Like, I mean, but we need. I mean, the trials are
Yeah.
ongoing. Let us.
Let's see what the
Wait.
trial says. And since you're a doctor who's involved in AI-driven solution for your hospitals, I think you will have a long emphasis on data capture for this antibiogram,
Yes.
infection prevention. So, any inputs on that? That how definitely we're waiting for all antibiotics in pipeline, but still how we can improve our current practice with the data that we have. Are you exploring that area of infection? I'm just exploring.
As an institute, we have this have like when there's a practice of collecting antibiogram for each clinical syndrome. As of now, we are collecting hospital-wide data. Like but we want to give site-specific data, ICU-specific data, ward-specific data, so that which will help in tailoring the antibiotic choices better. So again, like data is very important. Our own data, our own hospital data, our own state data, country data. We should all be like collecting them, publishing it, and so that we don't depend upon Western data for our problems.
Exactly. So we are also in in an effort, taking an effort to make a syndromic antibiogram. Yeah.
Excellent.
So actually, we have to wait for years to get that syndrome diagnosed. Like at least 30 sample size has to be there. So we are in the way of making that. So I think this is a good initiative and talk to have in our advanced series. So thank you once again for that wonderful session. We would like to collaborate with you more in the upcoming years. And
Thank you.
to all the viewers, keep watching our sessions. Thank you.
Thank you. Thank you very much.